At the very outset, I'll thank the organizers for inviting me here, and thanks to Dr. Rustam for kind words. I think the task given to me is to talk about complications in chip, and I was rather confused as to what should I talk about in complication, because most of the time people will talk about perforations, stuck hardwares. So I thought, let me just talk about a case which is maybe somewhat different from the usuals. So this was a 56-year-old man who underwent a bypass surgery. He received grafts for his RC and circumflex vein grafts. And internal memory was not very good. Also, the LAD was not very promising, diffuse disease, and also infarct related, so it was also treated with a vein. The diagonal appeared to be good without infarction, so it was given a radial artery. He did well for a couple of decades, and then he started having rest pain, markedly depressed left ventricular ejection fraction. Only graft which was working was radial. Everything was otherwise dysfunctional or gone. Both the native LAD and RC were gone, so were their grafts. The circ-OM graft was working towards disease, but the circ-OM was also knocked off. This was a degenerated graft, which I stented. I should have done something different, but that was the request of the patient. This patient was shifted to me from AIMS, and they said no CTO to be attempted, only vein graft. They had heard about some complication related to CTO. So I stented this. That was 5 years ago. He improved tremendously, symptomatically as well as the rejection fraction, and stayed okay. And about a month before this presentation, he had COVID. I don't know related to this disease or not. This time again, similar presentation, same ejection fraction, trop was positive. Additional degree was that he is CKD2. His ECG, poor progression of R waves, Qs in the lateral, and prominent R waves, or at least with whatever voltage, in the inferior leads. That was the occluded right, and not a good distal target. The graft to the RC was gone. Here, the LAD is gone, the OM is gone, and the left OM also has some disease. The only graft which was working was radial. Not only it was working, it was also feeding the OM retro, like this. Previously, this OM was getting antegrade flow through this stented SVG, where we had put stents, but this time they got knocked off right at the os. So that was a 9 centimeter tube of Zion stents occluded at the os. So I started to walk down with a whisper yes, which it did with a great ease. Mind it, no intention to open up this 9 centimeter occluded vein graft. But I thought this can serve as a reference for me if I want to take on antegrade. And also, since if it serves as a target for me, I will not have to hook the radial. And if I inject into radial, I am giving contrast, and also I am inducing spasm into that. So I thought, play smart. This looks very attractive, looks like a beak. And given that acute occlusion, ACS, top positive, I think it looks very, very attractive and very short distance to travel. So I thought, at least pull out this wire, because most of the time when we are doing antegrade, we give about 5,000 heparin. And after we really get through the lesion, then we complete the heparin. Unlike in retros, where we try to maintain an ACT 350 kind. So this was my playground, SOC territory. If I look at it, ostial disease here, ectasia, some moderate distal disease. But my memory, I lost the records, but according to my memory, I think it looked the same 4 years ago. So what looked to be an acute probably was not acute, even though the distance was very short. So I thought, start with AL, take a fine cross, and then whisper ES out of it. And as I was trying to connect to the vein graft, then I thought, let me drive my wire which I had pulled back into the vein graft. This is a whisper ES, so that will serve as a reference. But not very lucky, didn't find any microchannel. Not only this, the wire started to do some mischief. Then I thought, not strong enough. Have I done any harm by now? Anybody? So if nobody says no harm, I'll also assume there is no harm. At least the injection didn't show. Then I thought, let me inject through the tip of the microcatheter. Have I done any harm? Anybody? Why I'm having a stain? See, forward it cannot go because of an occluded artery. Backward also it cannot go because there was an osteal disease in the OMM. I didn't want to really aspirate because I have an explanation of this stain, so otherwise I would have aspirated. My explanation is forward it can't go because I didn't make any progress in the CTO body. And backward it cannot come because there is a osteal tight lesion in this OM and the microcatheter was fitting snugly into that. So this is very easily explained. Now I thought take some stiffer wire, escalate it to Gaia 2, and I'm able to walk beyond that target, but without finding the lumen. Well, in such a situation, what we expect is the target to be in this direction. But the target could be like this, or could be like this, and all of us know that we can have an altered geometry at the anastomotic site. So that can be tented, pulled or pushed down. So I thought with these two possibilities, I can gently work around. So I was gently working around with a Gaia 2. And suddenly this happened. Anybody has any guess? I was absolutely clueless as to what caused it. Well, generally the prompt reaction is, sure, go back.
Any dissection of osteal circumflex?
Actually, just a couple of seconds before this, because when this VTVF happened, we were not doing anything. We were just thinking what to do. And a couple of seconds before that, we had taken a shoot, which showed everything was fine. So I thought it is pointless to take a shoot because if we have not done anything, we have not pushed a thrombus air or not pushed a wire or a guide, so no dissections. So I didn't take a shoot because in a situation where you have a VTVF, trying to shoot things into a circulation, the only left circulation, often will result into problems. So with that wisdom, the quick response was DC shock and CPR, and the second response is kick the guiding out. It is kicked out. But because I had a lot of difficulty in intubating that small OM with an osteal stenosis, so I thought leave the microcatheter there. Because microcatheter is unlikely to produce any obstruction in that sizable left main circumflex. So again I am trying to think what is wrong, and the rhythm returned back to normal, and first thing which I did was I just pulled the wire back from the vein graft, from the OM into the vein graft. Now it is only seconds or maybe a minute or so that I get into an electrical storm. And this electrical storm is like, you have a VTVF, you shock it, for a while you will get sinus, then you will get VPBs, then NSVTs and VTVF, DC shock again. And those cycles, I really cannot count them, maybe some 20, 30 of such episodes took place. And now I'm at my wit's end, I really do not know as to what wrong is happening. So by this time, everything is out. I took out even a guide from the vein graft because it was pointless to keep it there. Now my patient is in sinus tachycardia on vasopressors and poorly contracting heart on fluoro. Now this so-called quiescence was only for again short time, maybe a couple of minutes. We were trying to figure out what is wrong. And of course, in between we had treated him with many of the chemicals which we commonly give to these patients, like Zalocard, Codron, Mexelf, Bicarb, and so on.
How is a radial graft?
Beg your pardon?
Radial graft, is it good?
Radial, we didn't touch the radial this time. So again, it was not a point to get into radial. So Now we are getting from bad to worse because these episodes are continuing, and in between, even if I get some rhythm, it is a worsening sinus tachycardia, falling systolic BP, narrowing pulse pressure, and heart, of course, on floor are not doing very well. Now this is the time I thought, let me take a check shoot, because sometime you can think like it was pointed out, is there a dissection at this circos or not? I took a shot maybe with half a cc, very less contrast. The LM is big size. Immediately after this, the guide is pulled out, if you see that. Reasonable size LM, and this clearing is somewhat less than what it would have been in the past, I think, just because the patient is markedly vasoconstricted. Other than that, there is no thrombus, no dissection, no air. So we thought at least nothing wrong from our procedure. Now we are able to barely maintain pressures with high dose inotropes, and that those cycles are going on. Usually potassium is the culprit, which we checked was found to be 5.4 in blood gas. There is no hemodynamic support, not even an IBP. Otherwise, I would have put him on some hemodynamic support and just waited. Now what to do? Anybody strong enough? Because I think that if you just leave him like this, without a hemodynamic support, this patient will dip. Even though I don't know the cause. Because pretty high dose of inotropes with the narrowed pulse pressure, marked tachycardia. In our experience, if you're not able to lay your hand on the cause and treat it, they will culminate into low output and death. Who wants to chase the CTO again? Do you want to take on this occluded SVG? 9-10 centimeters. And no matter what you do, you will be showering things distally. Well, I thought, chase the graft. Drove a whisper down and took a thrombosuction catheter, which I could take with ease, deep into the circoem, and make many suctions, but to get nothing. Nothing great was aspirated, as was the flow. If you carefully look at this ostium, it is like a funnel. And this area is without any disease. This gives me an idea of a Proxys device. So I thought if I jut my catheter into the os, then I can prevent embolization into the systemic circulation, and I can prevent embolization distally. Because unless the graft is exposed to the aortic pressure, things don't walk distally. So I tried to jut a catheter and take many thrombosuctions followed by reverse Fogarty with small balloon. And every time I do a suction, I always try to bring the catheter down to the descending aorta with strong suction so that I don't embolize anything into the graft or into the carotids. And then, of course, take it back. This is not this case. Every acute MI, whether CIRC, LAD or RCA, this is my practice. Even if I have to do 20 times, I don't bother. And no issues about maintenance of the wire. I start to get some faint flow, but NSVTs still requiring DC shock, and I'm on a very, very tricky wicket. Now, by that time, my thrombosuction device has become old. The stylet, this doesn't walk without a stylet, and with the stylet, it makes very little aspirations. So I did a gentle dilatation distally with a 1.5 balloon. Then this permitted me to take my thrombosuction device. The same activity is repeated many times. I start to get some trickle, but that is not enough, almost nothing. Then I again take that balloon and try to do a reverse Fogarty. And I find a spot which I thought it is better to dilate that area. So I dilated that with a very small balloon in the terms of diameter and length, and then 1.5 into 6. Because the larger the volume of the balloon, more will be the squeezing of the atheroma, proximally or distally. Then I do a reverse Fogarty with this, and I start to get some flow. What is very important is I am getting some clearing of the flow in the OM. Now this is hand in hand with this, otherwise very poor flow, but hand in hand with this clearing, my NSVT started to decrease. This gave me some courage. Then I thought, let me pull out the wire and see if the things are settling down. I might just After the wire, things are again looking the same. Then I thought, even though there is a large filling defect, forget about, because there is a reasonable clearance and NSVTs have become infrequent. Give thrombolytic or maybe 2B3 inhibitors and get out. As I was just trying to give a thought about getting out, my colleague told me, look at the groin. There was a hematoma. So my doors are closed to give him aggressive thrombolysis or 2B3 inhibitors. So then I have to take back the same system, went back again with the wire, again started to do a lot of thrombosuctions. It started to look somewhat better, but I was very desperate. Things were getting better, but I wanted them to quickly and significantly improve. That was not happening. So I deeply intubated the guiding catheter, this time took a bigger balloon and did a lot of thrombosuction with the help of reverse Fogarty. This balloon is getting pulled back into the guiding catheter. Now I was able to aspirate much more than what I was initially. And now my export catheter is also able to go distally. And of course, I'm taking care that when I'm withdrawing this, I'm retracting the guiding catheter. And when I'm retracting the guiding catheter, I'm having a strong suction on the system. With this, I start to get this kind of a flow, which is quite good. Not only this division, I'm also seeing a division up. This division. You start seeing a division up also. But what you see is there is a linear thrombus, which usually we don't see linear thrombi like this in the circulation. So made some more effort with thrombosuction. Now, mind it, this time what I'm trying to do is my guide catheter is jutted in so that I do not decant anything into the aorta. And then the same thing, going down, re-intubation. Now the flow is definitely much better. So there is a rapid improvement in the rhythm and hemodynamics, so much so that all vasopressors are off, I think in a half an hour times or so. And this patient was wheeled out of the cath lab conscious, but with this residual thrombus. And this residual thrombus, if we compare with the pre-shots, in the retro shot from this, if we focus this area, there was no thrombus here. So it has formed. How did it form? I really do not know. Finally, I think I just floated a wire at the aortic ostium so that just to check whether I made any problem at the aortic ostium or not. And there was no problem there. So what we did was, I think we call it a day. Groin sheath were pulled out. Next morning, a radial shoot was taken, which shows things are better. A day later, the thrombus chunk is again less, except a small area, this small area, which we stented. And after stenting, what we found was, it is not only that this SERC-OM 2 divisions are flowing. In fact, if you see clearly, these are the two divisions, bifurcating divisions of PLB, and another PD which is filling from here. So what was looking as poor target from RCA, because we had no filling from any side, it in fact was not a poor target, it was a good target. Everything was getting filled through this vein graft. I can just show you. This is the area which was getting supplied by this OM graft. So these were some of the shocks after a couple of weeks' time. That's what the LV was. See, only thing which is contracting well is SERC territory. Or of course also RCA territory. And as far as LED territory is concerned, large part is gone. So we started with something like this, with a poor distal target and occluded LED and circumflex. 2 episodes of ACS related to OM. What went wrong? Anybody? Wire into the SVG. Produce what? So that is what I also thought later on. And in fact, that is the interest of presenting this case. Because many times with a 5000 heparin, we leave wires here and there, because it is only during retro that we are careful about ACTs keeping 350. But in this case, this was the distal SERC-OM. And last time there was a vein graft which was flowing, had a degeneration. What we did was we connected with a stent. I think that was wrong on our part. But that was on a strong request from the patient that no CTO to be attempted, because CTOs can create complications. But otherwise what we should have done is, through this flowing artery, we should have seen the distal vessel and connected retro like this and would have stented like this. That would have not landed us with a problem of vein graft. But this time, with the graft closed, we thought we are acting very smart to see this distal circulation, which we didn't want to see through the radial, because to shoot contrast to the radial in a depressed LV, depressed kidney functions, and keeping a catheter in the radial which can produce rather smaller size radial. So we thought, act smart, and rather than injecting, just pass a wire, that will serve as a reference. But we tried to act smart but not intelligent. Why? Because this served as a reference. But since we struggled, I think, a little more than few minutes trying to connect it, and we were only on 5,000 heparin, even though we tried to pull it back in between, what happened was, most likely, as we were failing to connect during that short time, a thrombus formed on the wire. And this thrombus, through a thrombus which is already there in that SVG, which is there for last 10-15 days, it is little older in age. This fresh thrombus will not be pulled back through an occluded SVG. So this gets stripped off. Once it is stripped off, that is why it produces a picture like this of a linear graft, which was linear filling defect, which was not there just before starting the procedure. And this led to ischemia just because the collateralized vessel has a mean pressure of 35. And with a mean pressure of 35, if you produce a long 50% filling defect, that is good enough to produce ischemia. And ischemia of not only circumflex. One possibility, I think, in this case was that guide induced everything, which of course is a common thing. But the moment this thing happened, we pulled out the guiding. Usually if the guide was the culprit, then after pulling out the guide, at the maximum you might have 1 or 2 episodes. And if you do not reintubate the guide, if you are able to maintain the circulation, then usually these episodes don't take place. Well, it is still possible that rather than a thrombus being formed on the wire, the thrombus got pushed from the vein graft into this distal sarcoem. I think it is a far-fetched idea. If anybody can offer me a better explanation, I'll welcome that. So with this kind of result, I think my conclusion is that a deep intubation of the guiding in the form of wedging of a guide, which works more like a proxys, provided we do not wedge inject, we are able to take care of distal as well as proximal ambulation. And needless to say, if you wash and decant your guiding catheter down, so even if you push something out of your guiding catheter, you shift the ambulation distally beyond the arch, which was done in this case. So I think if you take some precautions, then maybe in some special situations like this, you can take on an occluded vein graft with large chunk of thrombus by the methodology which was done in this case. Is it post-COVID? Well, you cannot rule out because this patient had very high titers of anti-COVID antibodies. Why I'm saying is because 4 stents put 5 years ago, all of them get so much of thrombus. And this wire getting too much of thrombus formation, of course, heparin was not like 350 ACT, but 5,000 heparin was still given. So that will still stay conjectural. And finally, I'll say that a lot of people talk a lot of nonsense about these thrombosuction devices, and I still feel that they are not without utility. If you know how to use them, then so this I'm just trying to play you that this is one tara. This thrombosuction device is just like single string, single wire. If you have learned the art, you can play music. If you have not learned the art, then this thing becomes like ching, 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 and that 25-30 rupees is wasted. So thank you very much for your attention.